Today's episode is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered ambient technology that helps physicians be more efficient and reduce clinical documentation burden. We have a lot of that, Kristen.
Sure do.
To learn more about how the DAX Copilot can help reduce burnout and restore the joy of practicing medicine, we got to restore that joy. Stick around after the episode or visit nuance.com/discover-DAX. That's nuance.com/discover-DAX. Knock, knock. Hi. Hello, everybody. Welcome to Knock, Knock, I, with me, your host, Dr. Glaucomflecken. Again, this is your one-stop shop for all things eyeballs. You're shopping around for eyeballs, this is the place to be. And thank you all for being here. And I don't know what episode this is. I think we're in like maybe the 40s now. It's almost half a year. Maybe even more. Maybe we've been doing 6 months. We've been doing Knock Knock Eye episodes. I don't know. That's a lot of eyeball knowledge, a lot of topics. Hopefully you've retained all of them. You've all been receiving the quizzes, the pop quizzes I've been sending you, right? I strangely, I have not received any of them back. So something's going on. Are you not getting those? I don't know. I mean, if you want CME, actually, we don't have CME set up for this. Maybe we should. Do you want CME? Do you want continuing medical education? Or are you not in healthcare at all? You just like hearing me talk about eyeballs. I think it's just fun to listen to someone who's an expert in a thing talk about the thing they're an expert in. Do you agree? I find myself just listening to people. People who do all kinds of different jobs on TikTok. I'll just sit there and watch as they go about their job or talk about running a hot air balloon. I don't know. There's random things, but because they are so knowledgeable about it, it's compelling. So I don't know. Maybe that's what this is. So. People who have no real reason to know about eyeball knowledge, why do you listen to this podcast or watch me on YouTube? I'm not saying you shouldn't. In fact, I'm so glad you're here, but I'm always curious about that. All right, so this is what I want to do first real quick before we get to our topic is go through some YouTube comments. So I always I'm going to try to do this, whenever I think about it. And go through the last video's comments, see what people are saying. Because I like to keep up with the feedback, see what people want to hear about, see if you have topic ideas or thoughts, or you just really didn't like what I had to say about acute angle closure glaucoma. Let me know. Hey, I'm here. This is for you. And I want to make it the best experience possible for you all. Okay, so last week, the episode was what happens when toxicology meets ophthalmology. I'm going to start trying to do this where I bring my goal is to get a specialist, a doctor from all different specialties, from toxicology to psychiatry to OBGYN to neurosurgery to vascular surgery to family medicine. Get everybody on an episode of Knock Knock Eye. And we just talk about the ophthalmology overlap with our specialties, because you cannot find a specialty that does not have some kind of eyeball stuff in it. I'm telling you, it's true. It's true. Everybody. And that's the thing, because nobody knows anything about eyes. So that's why we're doing this, folks. That's why we're doing this. So anyway, last week I had Dr. Trebach, Josh Trebach, who's a toxicologist and emergency physician, does a lot of things. And we talked about mushrooms, poison control, anticholinergics, cholinergics, pupil exams. We went all over the map. And so I loved reading some of these comments. At Sean P. Leslie, and again, this is by the way, our new YouTube channel. So if you want to see the reaction, if you want to see video episodes of this podcast, by the way, it's at Glaucomfleckens, at Glock and Fleckens on YouTube. That's separate from my regular YouTube channel. We were giving YouTube a massive migraine, and so they told us we needed to separate the podcast from the skits. So I did that. Now we got two things posting videos, and it's getting very complicated, but whatever. You got to keep the algorithm lords happy. So Dr. Trebach and I, we talked, and Essie, here's some comments. At Sean P. Leslie, I love this episode. It was half an hour of two nerds enthusiastically going back and forth. Quote, but did you know about this awful thing? Yes. That's one of the joys of health, of practicing medicine, is you can just talk to someone, another physician, someone else, and just try to one up each other on terrible things you've seen. It's educational, and also a little bit depressing, but I'm glad it makes for good entertainment, I suppose. Also, and this user at Sean P. Leslie also says, also shout out to how amazing poison control is. A lot of love for poison control in the comments and the reaction to this episode. Ever since I learned about poison control in Radiolab, I tell all new parents about it. Yes, that's a good idea. At Nikki White 476, this is a great story. I called poison control once when my son decided to eat this substance from the wall. All good stories start there, and all parents can relate to that. It was a putty that had been placed around the electric wires leading from the outside to the breaker box. I was calling them in a panic because I didn't know what it was, and I wasn't sure how much he ate. They had to figure it out by my description. They said it was ceiling putty and that he should be fine, but to watch him for a few days. God, I tell you, every story I hear about poison control just gets better and better, because these folks, they have to take people that call poison control are like panicking. They are beside themselves. They don't know what to do, and you got to take whatever random information is thrown at you and try to figure out what's going on. What did they eat? How much of it? What color was it? Who knows? All these things. Plant matter, plastic, what's it made of? Was it metal? Who knows? So I'm just amazed by poison control, because they figure out stuff like this. Oh yeah, it must have been ceiling putty. Yeah, I mean, I'm not a handyman by any means. I don't know what ceiling putty is, and so great job on them to figure that one out. That's great. We also learned a new word on last week's episode, envenomate. Envenomate. Yeah. Some people were excited to learn about that. I know because I've been yelled at before. Like a lot of times I've been yelled at in my life in medicine. But I know not to say poisonous. An animal is not poisonous. They are venomous. And then by virtue of that, they will envenomate their prey or threats. So, and if you're thinking, why would you get yelled at for that? Well, why would you get yelled at for anything in medicine? All right. Like, you don't know what you don't know. Why are you getting mad at me for saying poisonous? I could do a whole episode on times I've been yelled at. Maybe that would be a good episode. I don't know. I'll think about it. Hey, so you guys seem to like that one. That was good. So we'll have some more specialists on. Just trying to think of what I'm going to talk about with the nephrologist. I don't know. Or even cardiology would be easy. Neurosurgery? Yeah, we could find some overlap there. Certainly OBGYN. We dilate things. What else? Gastroenterology? Oh, yeah, we got some good ones there. Yeah, I can, trust me. I'll come up with some that PM&R. Oh, that might be hard. Like concussions, like brain injury, traumatic brain injuries. There we go. See, I got it. Every single thing out there. Try to stump me. You're not going to be able to. Okay. All right. Let's take a quick break and come back with our. Actually, no. Before we take a break, I want to just say one more thing, because you guys know that as the foremost internet comedian ophthalmologist, I am told about everything, all the bad stuff that happens to people's eyes, like out there in the world. And so there was another episode, sorry, not another episode, another example, another patient, I'll say, another person who had numerous contacts removed from their eye. Now, a while back, there was like somebody, it went viral, it was like 27 contacts came out of this person's eye. And it keeps happening. Like there are certain things that no matter how much work people do to raise awareness, to prevent it from happening, to pass laws, to try to safety measures, whatever you want to do, laws. I'd be curious what laws we can come up to keep people from abusing contacts. I would honestly love that. I really would. It would make my job a bit easier. Or laws to prevent people from grinding metal without safety glasses. These are things that people will continue to do till the end of time, putting their eyes at risk, and nothing we can do will ever change it. People are still going to get metal in their eye, specifically, not really in their eye, on the cornea. People are still going to not use contact lenses correctly. The most I have ever pulled out of the most contact lenses I've ever pulled out of a patient's eye is 2.5. One time, usually it's just 2. Like people are like, "Oh, I had no idea I had a contact lens on the eye. I just put another one in." That's not unusual, to be honest. But one time there's like 2.5. Like one of them torn. They only got half of it out. I'm not sure if you only got half a contact out, why you would just be like, "Yeah, it's probably fine." But some people have that reaction. Some people freak out. It's really the psychology of how people react to eye problems is fascinating to me. And I don't think it's probably not just eyes. I'm sure it's just a problem with any like critical part of the body. Some people have a very laissez-faire, nonchalant, it's probably going to be fine kind of thing. Like, I'm sure it'll get better. Yeah, I've got massive vision loss. I can barely see a hand in front of my face. I'm sure it's going to get better. There are some people that just do not come in. Sometimes it's weeks. Sometimes it's months. And they've had an eye that sees nothing. And then there's more problems with that. Some people with just the tiniest little imperfection in their vision, the littlest new floater that comes up, bam, within a day, they're in the eye clinic. And I just find it fascinating. And the personality differences, there are two extremes to the spectrum, and then there's a lot in between, right? It's very interesting, and it's always sometimes frustrating to see patients who like, if you had just come in earlier, if you have massive vision loss, go see an eye doctor, go to the emergency room, go see somebody. All right, figure out what's going on there. All right. So I just wanted to talk about the contact lens thing because I don't think I ever told you the reason I brought that up and started ranting about contact lenses. Doesn't take much to get me going on contacts, you guys. I was sent another person who had several contact lenses taken out of their eyes. So this is a regular occurrence. It comes in cycles. There's the contact lenses. There's the foreign bodies. There's the chalazion. There's the eyeball tattoos. A couple times, every couple of years, I get a urine eye drop type of wellness thing. There's the sun gazing. There's people doing like vodka shots on their eye. God, that's a thing. Anyway, it's all over the map. All right, now let's take a break. We'll come back and talk about ptosis. All right, here we go. So ptosis. And so the reason I chose this topic is because, number one, it's a really common topic. There's a lot to talk about. But also, I want to do a little series on famous eyeballs. Famous eyeballs. I think that's what I'm going to call it. If you can come up with a better name for this series, like, please let me know. Celebrity eyes. I don't know. Famous eyeballs. But basically, I want to take somebody who's famous, who has a famous eye problem, And these are obviously just whatever I can find on the internet, right? So I try to do as much research to make sure it's actually a real eye problem or that they really do have this thing. And it's like well known. So I mean, clearly I'm not like divulging any new information on any of these people. But I think it could be fun to take whatever eye problem they have and just talk about it and tell you what it is, pathophysiology, treatment options, how debilitating is it? All these questions. Our first one is a very famous eye problem from actor Forest Whitaker. Forest Whitaker, just Academy Award winning actor, just amazing performer. But he also has a famous eye. All right, he has ptosis. His left eyelid is droopy. If you go and look up photos of him, you'll see it, and I'm sure many people know what I'm talking about. And so let's talk about it. In interviews, he has said that this is a hereditary thing. It's congenital. He's had it all his life. There's lots of different causes of ptosis. But first, what is ptosis? And why does it sound so weird and spelled so funny? It's Ptosis. Because in ophthalmology, we like putting P's and H's places. Like if there's a P and an H, we're going to find it and we're going to put it in a word in ophthalmology. That's just part of what we do. It's just OPHTHALMOLOGY. It's lunacy. It's lunacy. So ptosis is a word that means droopy eyelid. That's basically what it is. And so let's start with congenital ptosis or blepharoptosis, is because there can be ptosis of other things. I think ptosis just kind of means droopiness, but blepharo is bleph means eyelid. It's like blepharitis, inflammation of the eyelid. Blepharoptosis means droopiness, lowering of the eyelid. All right, so congenital ptosis. So this is most of the time it's unilateral, but it can be bilateral. The most common cause of a droopy eyelid from birth is just a congenital dysgenesis of the levator muscle. All right, so in fact, we should probably back up just a bit. Like, what is the levator muscle? So let's talk about just what the muscles are that close the eye and open the eye. How about let's start there, right? So closing is easy. The orbicularis muscle. It's this muscle that goes all the way around, and you close it. You have some involuntary ones and you have voluntary ones. Cranial nerve 7, the facial nerve, that's what allows you to close your eyes. So when people have a Bell's palsy, where you have paralysis of the facial nerve, you get a whole side of your face that doesn't work. That will prevent a patient from completely closing their eye. They'll lose their blink. And that can be dangerous for the surface of the eye, the cornea. It can get dried out. We have to sometimes do patching, lots of drops and ointment to keep the eye healthy. So that's the orbicularis, the cranial nerve 7, closing the eyelid. Opening the eyelid, a little bit more complicated. There's two muscles. There's the Mueller muscle, which is a small little wispy muscle that's responsible for maybe like 1 to 2 millimeters of eyelid opening. It's controlled by your autonomic nervous system. You don't have any control over it. There's no skeletal muscle there. It's smooth muscle. And there is surgery that you can do to kind of shorten that and raise the eyelid up just a little bit. We don't get real excited about the Mueller's muscle because, again, it doesn't do a whole lot. The big daddy, the big one, did I just call a muscle Big Daddy? I'm sorry, it's getting late. The levator muscle. All right, this is your big eyelid opening muscle. It is controlled. You know which cranial nerve it is? 3. Cranial nerve 3 controls lots of muscles around your eye, the extraocular muscle, but it also innervates. I should use the correct word. Innervate. It innervates. Sound like the neurologist. We're innervating the eye. The neurologist. Crazy guy. Cranial nerve 3, it innervates the levator muscle. which is the big eyelid opening muscle. Okay, so back to congenital ptosis. That's what you need to know about eyelid opening and closing. So dysgenesis of the levator muscle is the most common cause of a congenital ptosis. And so there's signs of this. Obviously, like a newborn should not have a droopy eyelid. It's fairly obvious early on. One sign that you have a poorly functioning levator is looking at the eyelid crease. We all have a little eyelid crease when our eyes are open. All right, if that eyelid crease is moved way up high compared to the other, there's a sign that either the levator muscle is not attached correctly, or it's atrophied, or it just is not there in the case of congenital ptosis. Maybe it's there, but it's just much smaller. Dysgenesis, it did not develop properly. And so what do you do about that? Well, with congenital ptosis, that's harder to fix, because as you'll hear about when you have like the more of an what we call aponeurotic ptosis, or just age-related ptosis in a way, you can actually shorten that levator muscle to raise the eyelid up. But in congenital ptosis, you don't have a levator muscle, and that's normal that you can use. So we use what's called a frontalis sling is one way to do it. And that's to get that eyelid up. What you do is you actually connect the eyelid to the frontalis muscle in the forehead. So to get the eyelids up, you'll just, right, and babies will learn to do this. You'll learn to kind of pull your eyebrows up. That's using your frontalis. You're contracting that muscle, and that allows the eyelid to come up as well. So maybe you're asking yourself, okay, Forest Whitaker, he's born with this droopy eyelid. Well, why didn't it get treated? Well, you don't always have to treat a congenital ptosis. The danger with a congenital ptosis is that if the eyelid is low enough, then it will cover the pupil. It could cover the pupil. And if that happens, you end up getting a lazy eye. That eye, if it's not seeing because the eyelid is blocking the visual axis, then the brain will not learn to see normal vision out of that eye, a condition that we call amblyopia. And so you got to raise that eyelid up however you can, patch the good eye, and force that eye to learn to see normally. And so in Forest Whitaker's case, that droopy eyelid, it wasn't droopy enough to cover the pupil and cause amblyopia. So then you don't necessarily need to have it fixed. In fact, a lot of doctors, a lot of ophthalmologists would not recommend fixing it if it's not what we call amblyogenic. If it's not an eyelid that's going to obstruct the pupil and cause permanent, lifelong vision loss, well, then you can just leave it alone. And often people will end up having surgery later in life. And that's fine. As a young adult, obviously it can be a cosmetic thing. So when kids get into school age or middle school, high school, or even older, you can always have a surgery to kind of try to pull up a droopy eyelid. But if you don't have to do it, it's probably best to just wait for a bit. So there you go. That is Forrest Whitaker and his congenital ptosis. But as I mentioned, there's other causes of droopy eyelids. Let's go through some of these. Now, I'm going to go through the most common ones are what I mentioned earlier, aponeurotic or involutional ptosis. Basically, the levator muscle just ages. Or if you have like chronic inflammation of the eyelid, you can end up with ptosis. The levator just doesn't work as well. And again, you'll see that eyelid crease kind of creep up. It's really high. And then you can do a surgery, and that's bread and butter. That I have done that surgery before. Once in my practice, we hired an eyelid specialist, an oculoplastic surgeon, and I was more than happy to just let him do all the eyelid surgeries. Blepharoplasties are kind of fun, because it's a really simple surgery. You just take off extra skin. Levator surgeries are a little bit more challenging. because you lay the patient back, obviously, to do the procedure. You tie off that levator muscle, and then you got to sit them up. Patient's awake, right? You sit them up and you look at them and you see what's the contour of the eyelid like? Is it equal on both sides? And then if it's not equal, you lay the patient back down. You redo parts of the surgery. You bring them back up. You check them again. And you're obviously warning the patient that they're going to be going up and down, and it's going to feel kind of weird. But again, painless, you guys. It's just it throws people off to hear that we do a lot of awake surgery in ophthalmology. All the surgery I do is awake. If I have to put someone on a general surgery, I'm doing some kind of big case, or the patient needs to be under general for a variety of different reasons. So that's not as interesting to talk about as the involutional. We see this a lot. It's very common. Again, you don't have to have surgery for any of these things, but a lot of people want it done either because the eyelid gets too low or it's more of a cosmetic issue. And the last type I want to talk about is neurogenic. I mentioned cranial nerve 3. So one of the signs of a cranial nerve 3 palsy is a droopy eyelid. Now, why do we get so concerned about this? Why do we often get consults from the emergency department? Because they're concerned about a cranial nerve 3 palsy, because maybe the pupil's a little bit larger on that side, because cranial nerve 3 controls the pupil. It controls pupil constriction. And so if you don't have a functioning cranial nerve 3, the pupil on that side will be larger than the other pupil. And obviously the eyelid will be droopy, and some of the extraocular muscles that are innervated by cranial nerve 3 won't be functioning. And so the eye ends up looking out compared to the other eye. So you'll have one eye looking out and maybe a little down. Pupil will be big. Eyelid droopy. That is like sirens going off. Cranial nerve 3 palsy, cranial nerve 3 palsy. Call an ophthalmologist. Call him again because he's probably not expecting to be called because he's an ophthalmologist. Keep paging him. Hammer page this guy. Oh, he probably doesn't even know he's on call. He's on call so infrequently. Let's just keep calling him. That doesn't always happen. Sometimes it does that way. But anyway, eventually we'll get in. And the reason it's so important to recognize this type of palsy is because it could mean an aneurysm. An aneurysm in the brain. And you don't have to be in healthcare to know that's a bad thing, because those things can rupture, they can bleed, and they can kill somebody. And so we're always very wary of any clinical signs and symptoms that could indicate a cranial nerve 3 palsy. So that is another cause of ptosis. Now, one interesting thing is because not all cranial nerve 3 palsies are due to an aneurysm. We always rule it out. And if you do see an aneurysm, obviously you can treat it. But sometimes you can have them just because someone has a lot of vascular problems and you temporarily lose blood flow to the third cranial nerve, I'll just call it the oculomotor nerve. That's what the cranial nerve 3 is. Do you remember your mnemonics? And so the oculomotor nerve, if you can have a vascular third nerve palsy where you just lose a little blood flow. Maybe the patient has diabetes or high blood pressure. The blood vessels are a little dicey and you temporarily lose function of the optic nerve. There are signs of that a nerve palsy might be that versus an aneurysm. I'm losing my words, you guys. All right, we're getting there though. So there's basically the point is not every third nerve palsy is an aneurysm. All right, but you have to rule it out. One really interesting clinical finding in patients that have had a cranial nerve 3 palsy and recovered from it is what's called a Marcus Gunn jaw wink. So when you can have aberrant regeneration of nerves. So nerves do heal, you guys. You may not know that. Nerves do heal. Sometimes they don't heal correctly. And you get nerve fibers that get attached to other muscles. inappropriately. And so with a Marcus Gunn jaw wink, all right, if you open your mouth, and I always forget if it's due to the external or the internal pterygoid muscles. It doesn't really matter. But what you'll see with this is the patient will open their mouth and they'll wink. They'll get a little bit of opening and closing of the eyelid, and that's because as the cranial nerve healed, it attached itself to these different things that it's not supposed to attach itself to. And so you get this cross activation of the cranial. It's a sign that someone has a chronic third nerve palsy. Like they've had a nerve palsy for a while, so long that the nerve has had time to regenerate in a weird way. So that's kind of an interesting thing. Another cause of neurogenic ptosis is Horner syndrome. I think I might do a longer episode later of Horner syndrome down the road. There's a lot to talk about with Horner syndrome. And then the other things, trauma obviously can cause a droopy eyelid, and you can have like mechanical issue, like the skin of the upper eyelid can weigh down the eye, weigh down the lashes and cause ptosis that way. These are less problematic issues. So that's ptosis. That you guys are like 8% of their way to an oculoplastics fellowship. Pretty cool, huh? I liked doing eyelid surgery, but it's one of those things that it's hard to keep up and really be able to do it well if you don't keep doing it a lot. And cataract surgery is the same way, which is why in ophthalmology, at least, a lot of people will go plastics, oculoplastics, because that's all they want to do, and that's all they end up doing. And then cataract surgeons just do cataracts. So it's a 2-year fellowship, and so God, I love our oculoplastics specialist. It's fantastic. We're about the same age, and it's I remember seeing him on the interview trail a few times, and just does incredible work. The things they can do behind the eye, orbital work, treatment for thyroid eye disease, and just all kinds of stuff. It really is. It's a reason they're basically kind of like the general surgeons of ophthalmology. It's they got a bit of swagger to them. They got a bit of that, a little bit of that surgeon ego going with the oculoplastics specialist. But that's okay. They've earned it. They do really, really cool things. All the tear drainage system stuff, their scope of practice is pretty awesome. The types of things they can do. It keeps it interesting for sure. Whenever they don't have comprehensive ophthalmologists sending them like styes to excise. I don't do that. I do my own. I incise and drain my own chalasia. Thank you very much. All right. You got a little plastics today, a little eyelid talk. How about that? All right, that's it for this episode, you guys. Let me know if you have any follow-up questions. Again, I'm going to be reading the comments to when this gets posted on my YouTube channel, the one at Glaucomfleckens again. So leave your comments there. You can also email us, knockknockhi@human-content.com. Thank you all for listening. Again, I'm your host, Will Flannery, Dr. Glaucomflecken. Thanks to my producers, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineer is Jason Portizo. Our music is by Omer Benzvi. Knock Knock Hi is a human content production. We will see you next time.
Knock knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.